Good afternoon, everybody. Warm welcome to you all. I will allow others to come through and join in just to accommodate for some of the latecomers, and then we'll make a slow start. But hopefully you're having a good day so far. Let me just... Hey, right, how many? So far there is 167 of you attending this webinar. It's going up, 73, 74, perfect. Okay, but I'll start shortly. Hopefully we'll reach 200. So we've run this webinar this morning and we had about over 300 attendees. So well attended webinar. So we're up to 187. Okay, perfect. I think we're going to reach about 200. Right, it's 1 minute past 1:30. I'll make a slow start. So again, good afternoon, everybody, and warm welcome. Please settle in. We are going to start now. So my name is Rommel Orig, and I am accompanied by my colleague here this afternoon, and his name is Joseph Singleton. Give us a wave, Joseph. And we are both tissue viability nurses from Coloplast, and we will be delivering and facilitating the session this afternoon. So welcome to this webinar, a coroner's court simulation. We're going to be focusing on leg ulcers. So this week, if you're not aware about it, is Legs Matter Awareness Week. And the focus of this year's campaign, if we look at the Legs Matter webpage, it's all about power of speaking up. So it's about the power of speaking up from a patient and a healthcare professional perspective. And here at Coloplast today, we are speaking up and sharing the importance of good documentation and leg ulcer management. That's what we're going to do this afternoon. So we will start the program by a session will be delivered by Joseph, looking at the importance of good documentation and what that good documentation looks like. And we will also hear from Joseph about how we can simplify wound management using the three-step approach developed by Coloplast. After that, I will facilitate, or we'll have a short break. It's probably about 5 minutes, just to give you a stretch break. You can have a drink, and then I will facilitate the coroner's court simulation. So at the end of the webinar, you will receive a certificate, a link to the recording of today's session, and also a copy of the pathways from Coloplast around the management of venous leg ulcerations and simplification of wound management. Now, in this webinar, we highly encourage audience participation in the chat. We will be doing some poll during the coroner's court simulation, so we encourage participation. So don't be shy. Again, I will repeat this. So we've got this to avoid any confusion. So at the end of the webinar, you will receive a certificate. You will also receive a link of the recording of today's presentation. No hard copies though, and you will also receive a copy of the venous leg ulcer pathway from Coloplast and the simplification of wound management. Okay, so without further delay, I will pass you on to Joseph to start the session. So over to you, Joseph.
Thank you very much, Rommel. Good afternoon, everybody. My name is Joseph Singleton. I am a tissue viability nurse for Coloplast. Really quickly, just a bit of background. I'm from Birmingham, so excuse the Birmingham accent. Hopefully you can all understand. I work as a clinical tissue viability nurse for Coloplast, so I actually am involved in clinics and still seeing patients clinically as well. And this afternoon, this first session is very much looking at the importance of your documentation. It's going to be a quick 45-minute succinct delivery and about maybe why the risks involved with poor documentation, a quick overview of leg ulcers in the situation around leg ulcers, and then when we might have to go to coroner's court. Anything that's unanswered in this little brief 45-minute initial presentation, we're going to get into the meat and the meat of in the later session with Rommel, the interactive session. Okay, so let's get into it. The importance of our documentation. So let's start by just, as it is Legs Matter Week, let's just start with a little bit of a definition of a venous leg ulcer. Okay, so we know venous leg ulcers are the most prominent chronic wounds within the UK and generally over most of the globe. NICE defines them as a break within the skin below the knee, which has not healed within 2 weeks. We used to be about 4 to 6 weeks, but we say 2 weeks now because it's really important that we get early intervention to manage leg ulcers. So if it's not healing within 2 weeks, that's the stimulus to why is it not healing? Let's look into it. Let's do a full holistic assessment. Ideally, we do that from day one anyway. Okay, so all patients who have a VLU should have a prompt full holistic assessment and treat the underlying disease ultimately, not just the wound, the hole in the patient, but the whole of the patient. So treat that underlying disease and start with appropriate wound and skin management. For those patients who have been diagnosed with the VLU, we need to make sure we get the key component on, which is compression therapy. Strong where patients are suitable for it. Reduced if there are any signs and symptoms, but we will talk about signs and symptoms that may prevent that, but we'll talk about that in a little bit. On your screen is the best practice statement, just as a really good reference. If you don't have this saved to your computer or don't have a hard copy, I would strongly recommend you logging into the Wounds UK website and downloading the second edition, the more updated one that was done in 2022. It's a wonderful resource for just that ongoing management of venous leg ulceration. It's a bit of a Bible, really. Okay, so moving on, let's have a quick talk about the financial costs of venous leg ulcers. So leg ulcers are horrific for our patients. They have a massive effect, causing loss of function, long-term care, high consequences to the patient, pain, social isolation, potentially. And they also have a huge financial burden, potentially on the patient themselves, but definitely on the NHS. There is a massive variation of practice across the UK, and sometimes it can be a bit of a postcode lottery how good venous leg ulceration care is. But what's really important is that we all start to educate ourselves and we are knowing best practice to tackle that. So financial costs of venous leg ulcers. Julian Guest, the health economist, did a lot of work over recent years trying to look into what the actual tangible costs are to the NHS, and through some wonderful health economics, he was able to come up with a figure of £1.94 billion. And that's just the treatment on venous leg ulcers. Okay, he worked out an average of 7,600 per patient with a healed VLU. So anyone with a healed VLU, the average of their cost is £7,500 pretty much, which is a big amount of money. That can increase to £13,500 for patients with unhealed venous leg ulcers, those leg ulcers that have not yet healed. The variation can be huge, but those numbers speak for themselves. And obviously, it's a massive drain on NHS funding and resources. So it is certainly something that we need to get better at. And we also know that prevention is better than cure. So we want to make sure that we are preventing a lot of these venous leg ulcers from becoming chronic, long-term, hard to heal wounds. Okay. We know that there are high recurrence rates of leg ulcers. And we also know that healing rates are not what they should be at present. Only half of people with a venous leg ulcer actually heal within a year. Okay, and that's quite a horrifying statistic when we think about it. It basically says that generally, nationally, we're not getting it right, and we're nowhere near getting it right enough. Where those patients who do heal, we currently see approximately a 70% recurrence rate in patients who don't have compression maintenance hosiery post-healing. Okay, so what's the important bit then is every patient who develops a venous leg ulcer, when we heal them, we should be getting them into maintenance hosiery or maintenance compression, even if that be a wrap device, to maintain their good circulation, their venous function. If that's not happening, the recurrence rate is incredibly high, and we're likely to see those patients back again. There's a lot of, as I mentioned a moment ago, there's a lot of variation in care across the country. And NHS Right Care, if you've heard of them, did a beautiful scenario pathways back in 2017. It was looking at suboptimal leg ulcer care versus optimal leg ulcer care to try to bring the differences to light. Now, I won't go through every point purely on a time basis, but I would encourage all of you to look for Betty's story via YouTube. There's a wonderful 5-minute video that can be shared with both healthcare professionals and patients that take us really succinctly through what an optimal pathway looks like for leg ulcer care and a suboptimal pathway. Looking at that screen there, we can ultimately pick out that suboptimal pathway means that full holistic assessments don't tend to happen. Poor care pathways are put into place and patients don't heal for a long time, and we end up with high total costs. In this case study, it was seen at about £5,500. When we implement an optimal pathway, good holistic assessment, excellent wound care management, good compression therapy early, we can heal the patient quickly, hopefully within good 6 weeks, and the cost is significantly smaller at only about £500. Again, I would encourage all of you to look into Betty's story if you are not aware of it. It's a wonderful little piece to support you in your practice and keep good leg ulcer management at the forefront of your mind. Venous leg ulcers can be horrendous for us and but mostly our patients. They have a huge impact on the individual's quality of life, which can, in worst case scenarios, lead to social isolation and psychological and mental health disorders. I've known plenty of patients in my career and still seeing patients today who are socially isolating themselves because they're worried about the smell of their ulcer, for example, keeping their family and friends away, which is impacting further on their healthcare because they are struggling to manage themselves on their own. That's just one example of how a venous leg ulcer can affect someone. There's potential for significant financial burden on a patient as well. Not everyone has a lovely NHS contract and can get such lovely sick leave. People often on individual contracts and don't have access to sick pay. If they have something like a venous leg ulcer, it can take them out of work and out of earning, which can have a huge burden as well. And pain is often a really significant factor with these wounds and is often underestimated and can be a barrier to healing. So the reason we want to highlight it today is just to make sure we are always addressing our patients' pain with venous leg ulcers. It is an absolute myth. If you've ever heard that venous leg ulcers aren't painful, they absolutely are. And we should always be asking for patients about their pain and making sure we are doing our best to control it to make them concordant with compression therapy and other forms of therapy we might want to do. Ultimately, accurate assessment is crucial to ensure correct treatment. So other impacts on the patient. Leg ulcers can lead to severe disabilities and in extreme cases amputation, and we might hear something about that later on today. It is rare, but it does happen. They might require extended hospital stays if people are admitted with horrible wound and leg infections, cellulitis or spreading wound infection. They might end up in hospital for long periods of time. Infection can also result in osteomyelitis, infection of the bone, which can lead to amputation or long-term treatment and long-term pain, and also to more wound chronicity, that wound taking a lot longer to heal. Leg ulcers can absolutely be life-threatening. Often venous leg ulcers can be seen quite trivial if something's small and not that big, but even the smallest leg ulcer can turn into something very serious very quickly if not managed properly. And in extreme cases, they can be life-threatening. They often result in the need for surgery or sometimes, as I said, prolonged periods of forced immobility as well, because having such a horrendous wound can affect people's ability to get footwear on, to mobilise their ankle. Range of movement can suffer, but also they can just make people feel really bad. The pain can limit people's ability to walk, so they become immobile, and then problems can get worse. So leg ulcers can have a huge impact on patients. Now, I mentioned earlier the best practice statement. The best practice statement for holistic management of venous leg ulcers is a wonderful Bible. And one of the things that it says to us, and hopefully that we all know because our local policies and procedures are telling us, is that compression therapy is the cornerstone for venous leg ulcer management. Okay, but we must make sure that it is appropriate to apply compression to venous leg ulcers. If the patient does have a level of arterial insufficiency, there is a risk that compression may cause further damage. So when we are assessing our patients, we should be looking for red flags. Okay, our red flags are the signs and symptoms that the patient is not suitable for compression therapy. Another point is we want to be starting to get people into compression as soon as possible. And in the absence of red flags, we can put people into 20 millimeters of mercury reduced compression, either bandaging or compression liners, like compression hosiery. That is fine in the absence of red flags while we are waiting to perform a further assessment of the blood flow, such as an ABPI and a vascular assessment. Okay, once we've done our vascular assessment, then we can move up into full compression. Our red flags, they're important to know. So if we do see a patient for the first time and we're assessing them and they have any of these red flags, we can't put them into compression until they've been referred on and seen by vascular, or full vascular assessment has taken place. Those red flags are acute infection. So if they've got acute unmanaged infection, we can't do it. We need to refer on, get them onto some antibiotics. If it's a mild infection, GP, antibiotics. If it's more severe, we might need to get them into hospital. Certainly if they've got symptoms of sepsis, so if they've got very high blood, high tachycardia, high temperature, or even very low temperature in certain cases, if they're pale, for example, if they've got fever-like symptoms, we might want to be getting them directly into hospital straight away. Okay, red lights if you suspect sepsis. Acute or chronic limb-threatening ischemia as well, if they have any signs of peripheral vascular disease, claudication, pain on walking, pale, cold foot, then obviously we don't want to be starting compression. They need a vascular assessment. Any suspected deep vein thrombosis as well, or any suspected skin cancer is a red flag, and they should be seen by the appropriate practitioners before compression is commenced. So, best practice recommendations again. Say when we've got a patient with an adequate arterial supply, once they've had their assessment and we've hopefully done an ABPI, or we've got the approval from vascular, we should be putting them into full strong compression, which is 40 millimeters of mercury at the ankle, either via bandaging, hosiery, or compression wraps. We also should be referring to a venous surgical for a review in case they are suitable for any interventions from the surgical team to maybe improve their venous flow. We should be monitoring their healing at least 4 weekly, at absolute least. And if no deteriorating or no significant progress in that wound after 4 weeks, we should be escalating it to an appropriate individual or service, such as the your local tissue viability team or your local vascular service, or potentially both. So that's a very quick overview of venous leg ulcers. It is very succinct just for time, because we want to get to the meat of what we've come for today. So one of the things that obviously can happen in the management of any patient is when we get clinical incidences. Obviously, none of us ever want those incidents to happen, but sometimes it is life, and sometimes we do have clinical incidents which can happen and can affect the patient and cause potential harm to the patient. And if that is the case, we need to report those clinical incidences. So this is just an example of a clinical incidence reporting process. I am fully aware that everyone potentially uses different reporting processes. This is based, the one on your screen, on the RCA model, but also there is the PSURF model, which is a bit less linear than RCA and is more about reviewing the systems in place as well. But this is purely the example we're using on the screen. So, clinical incident reporting process. Once the clinical incident is highlighted by the clinician, we report it on the system it should be reported on, making sure we're giving as much information as we can. Luckily, these systems nowadays are all blocked out and give you the asterisks of everything you should actually need to fill in before you're allowed to proceed. Once you've filmed in the report, it's generally we need it to be verified, such as for an example, for in a pressure ulcer, often we'll get a tissue viability nurse to come down and confer the clinical incident to make sure it is maybe a category 3, category 4. With a leg ulcer, again, it would be coming down, let's say the clinical incident has been put in because someone was put into compression bandaging, it was applied inappropriately and pressure damage was caused. You'd be getting your tissue viability nurse to come and verify that to make sure that it is actually a clinical incident. When that's been done locally, the RCA process, or whichever process you use, is instigated properly, and there's normally a review meeting to discuss the incident and decide on the next steps. And that's going to include a wide variety of healthcare professionals involved in that person's care, from district nurses to practice nurses, any safeguarding potentially, TVNs, podiatry, any other who have been involved in care and around that incident or is applicable to them. Then normally our duty of candour is flagged. So our duty of candour we will talk about shortly is where we contact the patient's family to ensure that they are aware of the incident. The RCA investigation, if deemed appropriate, is then deemed appropriate, and an RCA investigation is performed. And this will often be with the lead investigator reviewing the patient's records and their notes, and maybe interviewing the actual clinicians and patient or any family as well to get the full history surrounding the incident so they can look into the factors that are attributed to it. After they've done that, they can hopefully determine the root cause, because they should highlight why the incident happened, and they can make recommendations on how to prevent that incident happening again. If that's the case, it's often fed back to senior management, but it should be also fed back to the local teams so they're aware of any lessons in their local area and the actions that have been put in place to prevent a further incident in the future. So again, hopefully most of you know that process already. It's just a really quick little tour through what should be happening so we have it in our heads. Okay, so unfortunately, when things do go wrong, there are consequences within healthcare. And this is a little slide just very briefly to show the possible consequences. Again, for time, I'm not going to go through every single one, but there are varying different consequences that can happen when we do get it wrong or we have a clinical incident with a patient. If an incident we think potentially or a category of incidents lead to a patient's death, and it's not clear why that patient died, the patient is probably going to be referred to a coroner for a coroner's inquest, which is what we really want to dig in today, and we will be diving into later. But other things that are potential to be referred through these incidences are NMC fitness to practice tribunals, our own practice being and our own fitness practice being put under a microscope, which isn't a very pleasant process. Employment tribunals are our employers actually looking to prove that we've done wrongdoing to be able to potentially dismiss us. We might go into civil claims and negligence claims from families if it's deemed that we have, as healthcare professionals, we've been in the wrong and been negligent, so they could effectively sue us. And other areas of, you can see, Crown Court magistrates or court of protection. And just quickly, court of protection, for those who don't know, is the court that comes in when there is a mental health order over the patient. So if the incident is around a mental health patient and the Mental Health Act has been enacted, then a court of protection will be stepping into review, because it's a specialist court aimed at with mental health and protection of that patient's rights in mind. Okay, so moving on. One thing for us as nurses that we should always keep at the forefront of our mind is that we are, as professionals, we are personally accountable for our own actions and omissions in your practice, okay? If we do an action, despite if someone told us to do it or not, we are responsible for that action and that care in our practice. Now, we make judgments as nurses, judgment calls all the time, some in sometimes very high pressure situations with a lot of stress involved. And sometimes it's very snap and reactive. Hopefully our training has come in well and we're well prepared for this. And if we're not, hopefully we're always speaking to colleagues and asking for support when we're unsure. But we are always making judgments in practice. And using our professional knowledge and skills, it should be evidence-based and, most importantly, based on the patient's best interests. So as healthcare professionals, we always need to be able to justify the decisions we make. And our documentation supports those decisions, okay? Our documentation is there as the evidence for what we did. So if I went and I put a cannula in somebody, I need to go and document that that's what I did, but more importantly, why I did it, okay? Venous access needed, unless that is already documented as well, okay? But our documentation supports our clinical decisions. It's the evidence that we did what we said we did and why we did it, okay? So in a court of law, if ever scrutinised through any means, we have that defence to say this is why and this is actually what happened. Okay, moving on and slipping back into duty of candour. If my slide will go, sorry. We have a professional duty of candour, and that duty of candour is to be open and honest. And we could do a whole session around duty of candour ultimately and why this has come into place. But ultimately, duty of candour came into place because we weren't being open and honest enough with patients, family members and carers when there was a clinical incident. They'd often not be aware that there was harm that had happened and that was being investigated until it was brought to their attention down the line, if some cases at all. So it is really important that we are being open and honest with our patients, carers and family, that we hold our hands up when something hasn't gone as it should have done, and we let them know that we take it seriously and we will be investigating it. In my experience, and I'm sure in most of your experiences, when we do our duty of candour properly, our patients and our families are so much more open to discussing with us and are much more happier when they know that things are being addressed. When they feel like they're not being given any information or not being informed on processes around incidents, that's when they're more likely to take offence and more likely to want to take us to litigation, for example. Okay, so I would also say to you all, if you don't have your duty of candour from the NMC guidance visible on your desktop at home or as a little aid memoir in a file, I absolutely would have it accessible, just so you always can remind yourself why duty of candour is important. Okay, because it's something that often gets forgotten, and then we struggle to understand why we need to do it when an incident comes around. Okay, guys, so moving on to the role of the coroner. Okay, so I think the coroner, fair to say, is often seen as the boogeyman. And we're all terrified when we hear about coroner's court. As healthcare professionals, we are incredibly terrified of being called up and having a microscope put over us and our practice and what we did, especially if there's a chance that we might be deemed to have been negligent in our practice. Okay, but I think it's really important to always remember about the coroner is the coroner is not there to apportion blame. Okay, the coroner's jurisdiction is purely limited into determining 4 key factors: who the deceased was, how, when and where they came by their death. That is all the coroner is trying to do. After he has ascertained all of those facts, then he is able to recommend or able to put into place further on referrals, which we'll talk about later. So ultimately, when does a case go to a coroner? So when the death is suspected to have been either sudden, with an unknown cause, violent or unnatural, it will be generally referred to the coroner. The coroner then will decide, after reviewing, whether to hold a post-mortem examination and if an inquest and a coroner's court is necessary. Okay, so he will have a little look at it all and then decide. If the coroner thinks an inquest is needed, he will try to call an inquest relatively quickly after the death. As we know, we want to get on top of things and understand what happened quickly while it's all fresh in our minds and while the documentation is there and able to be accessed easily. The longer it goes on without an inquest or without looking into this, the harder it gets. So coroners tend to be called quite quickly. If the coroner is unable to call an inquest within the first couple of days or week since the patient's death, he'll often hold a pre-inquest hearing. Now, the pre-inquest hearing is purely about the coroner to open the inquest, ultimately, officially, and then he's going to decide how long this inquest needs to be, exactly when it will need to be held, whether a jury is needed, or whether any other types of hearing is needed. Just on a note of juries, it's very rare that a jury is present at a coroner's inquest, and they tend to be only there if it is clear before the inquest starts that there has been some unlawful applications to the patient's death. So somewhere in lead up to the patient's death, there has been a breaking of the law. Otherwise, it's very, very, very rare you'd ever see a jury at an inquest. So what is our role as healthcare professionals in the coroner's inquest? See, our duty is to the court and to the coroner. Okay, it's not to anyone else. What we will be doing is expected to answer questions clearly and factually under oath so that they are true. Okay, that is all we are there to do. It is to fill in the blanks to what happened. The coroner is not trying to apportion blame, though that often sometimes can be tried to happen with legal representations there. As we'll see in the video later, that's not tolerated by the coroner. They're not there in interested blame. At the end, they will make their judgment. But during the hearing, it is just about learning the facts. So this is where your documentation and your records support you in answering the coroner's questions. Now, I have been very lucky to have been able to attend coroner's court a couple of times to see how everything's happened. I have been called up twice in my career as a tissue viability nurse to attend coroner's court and to give evidence. And in both times, I didn't have to give evidence. And in both times, in one time, the coroner decided he didn't need tissue viability. It wasn't actually viable with the reason. The second time, I was actually written to by the coroner to say, I don't need to see you, Joseph, in court because your documentation was good enough. And it's not a day goes by where I'm like, thank goodness I was on my game that day and documented thoroughly. Your documentation can be almost a get out of jail free if it's good enough and if it's clear and it explains everything to the coroner that you did on that day. Hopefully his questions are answered and he'll be like, I don't need to see that person. I don't need to ask them more questions. So that is ultimately why our documentation is so important. It gives us a big level of protection, but it just gives us factually what we did, when we did it and how we did it, and hopefully supports the excellent evidence-based practice that we delivered to our patients. When you are in the coroner's court, if you are ever called up to give, it is important that you only ever state facts when giving evidence. The coroner, it's all the coroner is interested in. If you go on assumption or what you think may have happened, the coroner will dismiss it. He's not interested. He only wants what you know happened or what you can evidence as fact. If you don't know the answer to a coroner's question, if you're ever on the stand and causing, you don't have to answer we don't have to give an answer if you don't know the answer. It is fine to say you don't know. It is then up to the coroner to look to other sources to get that answer that he needs. Okay, so it can be a very intimidating scenario. It can be very high pressure for healthcare professionals and friends and family involved in coroner's court. But ultimately, it is just about getting the facts of what happened. Just to let you know that coroner's courts are public in the UK, so that if you do want to attend a coroner's court, you are fine to do so. You sometimes can be granted if you're in a role where you might have to actually go to coroners. You might ask your employer if you can have a bit of time to attend so you can get an feel for the actual environment of a coroner's court and observe a coroner's court in full swing. I did it and it was a very big benefit to me as well in learning the process and the type of questions that are asked in the environment. Okay, so once the coroner has heard his hearing and he's heard all of the evidence from all of those who have been called to give it in relation to the case, he will, based on the facts that he has heard, he will issue a verdict. And this is what the coroner is ultimately there to do, a verdict on why that patient died. And on the screen here are the different verdicts that he can give. First, natural causes is when it is clear that the patient died of normal natural causes or normal medical happenings or their own poor health, and it was not contributed to by human intervention. Accidental death or misadventure was when the deceased has taken deliberate action that resulted in their death, but they did not mean to kill themselves. For example, an intravenous drug user who issues themselves an overdose, goes into respiratory arrest and dies. They didn't intend to kill themselves, but that was the eventual outcome. An unlawful killing verdict is where there has been a breaking of the law, and that would be sometimes seen as found as either murder, manslaughter, infanticide, or potentially something like a serious driving offence. Suicide is another verdict if it's clear that the person took their life willingly and of their own conscious, uninhibited mind, then the coroner can say suicide. Neglect is another verdict where there's a gross failure to provide the needs given to the patient, okay, or the person in the institution that they were in. And obviously this is not something that we are ever wanting within our profession to get a verdict of, because that ultimately says that it was probably, again, been massive failings on one individual or multiple individuals, or potentially the trust or organisation itself. One of the most common verdicts is a narrative verdict. That is where there is the the reason for death doesn't fit into any of those others, but there are clear circumstances that have affected that patient's outcome of them dying. Okay, it could be multiple things that have gone wrong or not happened as it should have done, that no one clear was this is why the patient's died, but more like we don't know if this would have caused the patient's death, but it will have contributed potentially to their decline. So in that narrative verdict, the coroner sets out all of the circumstances around the death in a detailed way based on the evidence, and he will then, if he declares a narrative version, likely, if he has found that there have been some omissions in care or problems, he will issue a Regulation 28. A Regulation 28, after the inquest is closed, is a prevention of future death report. That goes to the institution or institutions where the patient would have been looked after leading up to their death. Okay. If he found that this death was potentially avoidable, if there was potential actions that could have been taken, he will list what these actions are and suggest them to the organisation. The organisation will then have the power to make those changes, and they must respond to the coroner within 56 days of receiving the order, showing how they have made changes or plan to make changes in over a time frame. So the coroner can be satisfied that the organisation is taking things seriously and addressing them and has safeguarded to prevent this happening again. Again, if that's not clear for everybody, we will talk about it a little bit later on. So bringing me nicely into record keeping again. Okay, our clinical governance and documentation rules and laws and policies are there to protect us and our patients. It is an integral part of our practice, that good documentation, and it is essential to deliver safe and effective care. There's a lovely little statement at the end of that first paragraph. It is not an optional extra. Now, I know sometimes we are an incredibly busy profession. We are in a high stress profession, often understaffed and often under-supported, where we are put in positions where we don't have the luxury of lots of time to do everything in nice, calm manners. We should never let our documentation suffer when we are faced with those situations. Where we do, we are opening ourselves up and our organisation to litigation and scrutiny. Okay, and we're potentially putting our PIN numbers on the line. Okay, for example, let's say you have 4 patients you need to go and see. You're a district nurse and you're out and you've got 4 patients to see in the afternoon, but you know you've not got the time. Rather than try to struggle to see all 4 quickly, prioritise those that definitely need seeing that day, and if you can, pass one over to the next shift. Okay, see those 3 and make sure your documentation is good for the priorities that you need to. Okay, that is okay to do it if we are able to justify patient safety, okay, which ultimately is our main concern as healthcare professionals. Now, it's always important to aware at this point that records can include anything that makes reference to the care of the patient, and any record can be used as evidence or called as evidence as part of a serious incident investigation, okay, a disciplinary hearing or a coroner's court. Those forms of records, such as paper records, anything written down that pertains to the patient, that could even be, if you're in a patient's home and you'll write some notes for yourself on a scrap of paper which you leave behind, that could still be called if found by the patient's family and made aware to of the courts. Any electronic emails, any electronic communication between healthcare professionals and patient, friends and family can be called. Any handwritten clinical notes, any letters to or from healthcare professionals, care plans, wound and risk assessment forms, photographs can always be called as well. And a little caveat here, photographs are a wonderful way to document within wound care the actual presentation of a wound. We should always be documenting the appearance of the wound well, but photographs provide a brilliant aid memoir there as well, and excellent evidence that the wound is in the position it says it in. So I'd always encourage regular photography where possible and able when we're managing a lot of these chronic wounds. Laboratory reports can be called, x-rays, telephone conversations as well. Sometimes they have been transcribed by patients or by healthcare professionals, and they can be called. Patients can even call a telephone conversation they had, recording it by memory. It is often down to what they said versus what they said, but it can still be used as evidence in a court. And medication and drug charts. Now, there's a lovely little old adage that everyone will know, we all know, and though not technically true, is very important that we probably do hold it as true. And that is, if it's not recorded, it didn't happen. Like I said, though this is technically not true because plenty of things can happen where they're not being recorded, if we ever have to prove what we did, it needs to be recorded because that is the strong evidence to say we did what we did at the time. And sometimes when that is that lack of that evidence there, it can easily be seen that it's our word against someone else's or the patient's word against ours. And there's a good chance it may not have happened and we are just saying it happened. That is why we need good documentation as that strong evidence. But not just documentation, careful and accurate records. The more detailed, the more care put into the record, the more likely are that they are going to be stronger and more robust at defending us against claims of negligence. So, common problems that we see with documentation. Absence of clarity. Okay, I'm not going to go through all of these just for the absence of time, guys, because they're pretty simple, you can read them. But absence of clarity, if you're very brief and succinct and you're not giving much detail in your documentation, you're not clear in exactly what you did or what you said, it is easily to cause issues and it causes potentially missing information, but it causes clouding and we're not sure if you actually did what you said. So it has to be clear, okay? Another one I'll take is failure to escalate. Again, we are so busy in our professions as healthcare professionals, and we can be up against it. Often if we see something's wrong or we notice something that isn't quite right, we should always escalate if we can't deal with that problem here and then. But often when we are very busy, we might fail to escalate, and that can be really dangerous. And we just say, I'm going to escalate that to my senior tomorrow. I don't know about if this wound's infected, I need support. I'm not going to do it now. I'll do it next time I remember when I'm back in the office. That could be 3 days away. And in that time, the patient may have come to harm or may have deteriorated. We fail to escalate that issue, then we are at fault. So it's important, if you struggle to escalate, you put a reason why, but more importantly, you put, I'm going to escalate this as soon as possible. And you do that. Okay. So, examples of common issues found in patient records. Though I've been in a few coroners court, as I mentioned earlier, and some of these are actual examples taken from that, where we've seen lack of information. So leaking, this is one of my pet hates, and I think Rommel's as well. Leaking plus, 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 or plus, plus, plus. What does that mean from a wound? Plus, 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 plus. That means nothing to me, and it's not going to mean anything to a coroner. It's not descriptive. It only means something to the person writing it. I imagine it means high levels of exudate, but how high levels of exudate? Is the dressing full? Has it been leaking through the dressing? Has the dressing contained that exudate? There is no detail there. So it's really hard to hang anything on it. Dressed as plan. I'm just going to choose another one. And dressed as plan is another bugbear I have. What's the plan? Is it the plan that was in place 3 weeks ago or the plan that was changed yesterday for the person who saw the patient that you didn't realise had been in to see them? So you must make sure that we know what the current plan is and we're saying what we're actually doing, not dressed as plan, that we say we instigated current plan from this date, which is current plan, or even better, actually document what you've done. And this is the current plan. Okay. So making sure that, again, last one, compression applied. What compression applied? 20 millimeters of mercury, 40, light, full, wrap, bandage, hosiery, being descriptive, something that can't be challenged and it's factual. Often these things can be rectified with 3 little words, okay? So don't leave yourself open by being super brief. Add that extra little bit of context, extra little bit of information, which gives you a bit more and gives you that evidence to say, actually, you did do it. So let's take, again, I'm not going to go through all of these, but let's take a couple as example. So wound to leg. If you just write wound to leg noted, where is that wound? There could be multiple wounds on the leg. If you mean left medial malleolus, say left medial malleolus. The medial malleolus, for those of you who don't know, is the bony prominence on the inside of your ankle. You are being descriptive, you are being specific. There's no doubt where that wound is, and it couldn't be confused with another wound. So I reviewed the wound at the left medial malleolus and noted there was no signs of infection, for example. Skin vulnerable due to, what's it vulnerable to? How is it vulnerable? What is that vulnerability? You're not being very detailed. Is it vulnerable because it's paper thin because the patient has been on long-term steroids? Is it due to the fact that there's excess moisture on the skin and there is excoriation or maceration? Being specific gives so much more context and leads to much more strong documentation. So next time you're out and you're being quicker under pressure, try and think, what other 3 little words can I add in which just give more and give more description to my documentation? Okay, everyone, I realise that that is very, very quick, 40 minutes through, just leading up to quick overview of leg ulcers, current what's going on in the UK, and then obviously when an incident happens into why we might be going to coroner's court. We could delve into that much more in our afternoon and our later session. We're going to really get into the meeting. It's going to be super interactive and we're going to be looking a lot closer at those. So if you didn't understand any of that, hopefully it will become a little bit more clear. Before we take a little 5-10 minute break, I'm just going to have a go through the 3-step approach by Coloplast with you. Now, as I mentioned, it's really important that we are doing everything we can for our patients to ensure we are managing them in an optimal manner. And sometimes using a pathway or a tool can really help us do this. Coloplast has developed the 3-step approach, which is a really easy and succinct way to remind us how we treat a wound or the best way to treat a wound. Okay, and it consists of step 1, which is assessment. So doing a full holistic assessment of patient at point of presentation, where we can to understand the patient and hopefully develop a underlying diagnosis for the underlying etiology of the wound, allowing us to set proper treatment objectives. Step 2 is then to prepare the wound, to physically clean and remove debris. And step 3 is to treat the wound, choosing a suitable dressing that is going to maintain an optimal healing environment. These 3 steps, when kept in our head, will really help guide us through good wound care. Now, to put a little bit more meat on those bones, it's really important that we're doing that holistic assessment, as I said, to make sure we're understanding the patient in entirety, and we're looking to get a working diagnosis for why that wound has not been healing or why it may have been there. Sometimes it's easier, it's a traumatic wound that happened 2 days ago. Brilliant. But we need to understand the risk factors associated with that patient. Does it have the potential, if on the leg, does it have the potential to become a venous leg ulcer or an arterial leg ulcer? So we should be doing our full holistic assessments. What comorbidities do they have? Are they diabetic? Are they in cardiac failure? Are they being managed for those diseases? If not, do we need to ensure the GP is referring them on, or do we need to get in contact with those healthcare professionals to ensure that the patient is being managed appropriately? We also need to consider things with the wound itself. Okay, so after we've looked at the whole of the patient, we can start looking at that hole in the patient. Okay, and certain things that we should be considering are certainly the depth of the wound. Okay, 80% of wounds are less than 2 centimeters deep. There is always some kind of cavity, even on wounds that look superficial. Our wounds aren't perfectly flat. They often have quite a bit of a topography to them. They have dips and areas where exudate can pool in areas of the wound. And when we have gaps and exudate is allowed to pool, that can have severe consequences, leading on to things like increased bacterial bioburden, increased slough formation and debris formation in the wound, increasing our risk of infection. So we should be looking to address that. Also, we should be looking closely at the edge of the wound and peri-wound skin, not just the wound itself. When we look at the edge of the wound and peri-wound skin, that can tell us lots of things about how the wound is healing. Is it contracting appropriately? Is the surrounding skin and peri-wound skin in good condition? Is there anything we can do to get it in good condition to aid the healing of the wound, such as moisturizing? Or is it macerated? Are we using the right dressing to prevent exudate spilling onto the surrounding skin? So we should be doing that full holistic assessment of the patient, but then a really good thorough assessment of the wound. So when we have moved on, we've done our full assessment and we understand that patient better, we can start to prepare the wound, and also ultimately prepare the patient. Now, this lady you can see in the top left is a lady called Donna Welsh. She's the podiatry operations manager up in Hull. And she gave us a lovely quote when she was doing some work with us at Coloplast. It's not what we put on a wound that heals it. It's actually what we take off the wound. And what she's referring to there is referring to proper wound preparation, cleansing of the wound to remove those barriers to healing. Okay, slough, non-viable tissue, and biofilm can all delay our wound healing, especially in wounds like leg ulcers. So the removal of those things through good cleansing and good mechanical debridement of the wound can significantly reduce risk of infection and improve our healing times, but also help us see the wound bed in full. If we have lots of slough there, we don't know what's happening underneath it. If we're able to clean and remove that slough in a more timely manner, we can do a better assessment of the wound itself. Delayed healing can also lead to decreased patient quality of life, increased clinical time and cost burden, as I mentioned earlier. So cleaning and physically preparing the wound, we know reduces that time significantly. It's more likely to save us more money and less pain and hurt for our patients. Wound preparation should be routine and regular. Okay, it's not something that we do once and forget about it. It should be something that we're doing every dressing change when deemed appropriate, to clean and remove those debris and break up the biofilm and bacteria within the wound, optimizing our dressings and optimizing our patient's immune response and healing response. As I mentioned earlier, we often get a gap with our wounds. As you can see, it's a leg ulcer here in the photo below, and you can see that even though it looks relatively shallow on a photo, it was actually quite deep. It was still below 2 centimeters deep, so it was about within 0 to 2 centimeters. And you can see with the dressing there, actually where the dressing has conformed into the wound bed to show the depth. When we have that gap and we're not conforming to the wound, that's when we get pooling of exudate and bacteria is allowed to breed, and our risk of infection significantly increases. There was a survey done of key opinion leaders across the country. So that's people, leaders in wound care, in vascular, and they all 98% agreed that managing that gap, reducing that dead space in between dressing and wound is incredibly important for effective wound healing. And 83% agreed that the best dressing for choice for wounds up to 2 centimeters is a dressing that conforms to the wound bed to fill that gap, to keep in contact, to sequester bacteria away, to pull exudate away into the dressing, and keep a lovely moist healing environment at the wound bed itself. Now, what I'd like to share with you is a patient of mine that I saw last year. So as I mentioned earlier, even though I work for Coloplast, I'm still a clinician. I'm working clinically. I run a clinic 4 days a week in the Midlands, and I am fortunate enough to be seeing a lot of leg ulcers. I think 75% of my caseload are lower limb wounds, and I would say probably 90%, 80 to 90% of those are venous leg ulcers. So it's a lot. And this particular patient was an absolutely lovely gentleman. He was a 67-year-old male. For the purpose of talking to you, I'm going to change his name and just call him Bert. Bert had a venous leg ulcer, and he had this leg ulcer for 18 months, and he was a train mechanic. So he's a private contractor to repair trains. So different train companies would call him in when they needed trains fixing, and he's a very busy man driving around the country fixing these trains. But because he's a privately owned, he had no healthcare benefits, and he obviously didn't have any sick pay. His ability to work was his ability to still afford his life. And you're probably thinking, why wasn't he retired at 67, which is a question I asked him. And one of the things is he loves to work, but B, he supported a big family. He still had a bit of a mortgage. He needed to work to maintain his life and to top up his pension. So he wanted to. And to maintain his own health as well, in his own mental health, he felt like work was really positive for him and kept him fit and healthy. Now, I said he had this wound for 18 months. He had been going to his GP, and his GP had literally just, when he had an infection, was giving him antibiotics and giving him dressings. His practice nurse had just given him dressings, multiple dressings to try see if they would heal the wound. As we all know, dressings don't technically heal wounds. They provide an optimum healing environment to aid the wound to heal. So eventually, when my clinic became known to the practice, he was referred in. And on the 23rd of the 4th, 24 was the first time I saw this gentleman. That is a picture of the wound. He was just coming off an infection, so he was just about to finish some antibiotics. So the visual signs of spreading infection had been rectified, but his wound was still quite heavily locally infected. You can see that this was a venous leg ulcer. I did a full holistic assessment. His arterial flow was fine. His ABPIs were in and around 1. And he had no claudication and good sensation and blood flow. It was clearly his veins. He had some hemosiderin staining, ankle flare. So his veins had popped on his ankle. He had some varicose veins, and he had edema. So it was classic venous presentation. His wounds, as you can see there, look quite red and beefy. But when I tell you that I started to prepare those wounds and I started to clean them, that a lot of that tissue came away. It was actually really unhealthy hypergranular tissue, and it looks to surface there, but when you look at the next photo, which is a month later, you can see there's still a bit of depth. So when actually I debrided and I was preparing these wounds, the wounds were actually quite deep. They were easily down to just under, well, about 0.5 centimetre, which is quite deep for the wound. Now, I did regular preparation twice a week, and we implemented initially, because there was local infection, fibril granulation, tissue pain and malodor. We instigated using biotin silicon AG as a one solution to lower the bioburden and keep a nice moist wound healing environment. After 3 weeks, signs and symptoms of the infection had gone, and we switched to biotin silicon. At this point, we were also able to implement supported self-management with the patient. He was able to prepare his wound himself using the all prep pad, and he was able to apply his dressing himself, his biotin silicon himself as well. And obviously he'd gone into full compression, and his compression of choice was a compression wrap. So he had been using a compression wrap, and you can see on the 28th of the 5th, 24, you can see that obviously with compression wraps, it was due on how he was able to apply it. So you can see that when he had taken his wrap off at night, he would get a little bit of rebound, and he would put it back on and it would shrink, but you would also get a bit of the indentation from the dressing. But his wounds healed beautifully, and within 6 weeks, his wounds had fully healed, which you can see on the 11th of the 6th, 24. So really good, strong compression, and following the 3-step approach, a really simplified approach to get this gentleman's leg ulcer healed, which had been bothering for 18 months. The only reason he really pushed his GP for extra referral was because one day he'd gone into work and one of his colleagues had said to him, your wound really stinks. We can't be around you anymore. So that's when he went to his GP and said, I'm sick of you just giving me dressings. I really want to see someone specialist about it. Unfortunately, the clinic was there to be able to see him. Okay, so hopefully that proves a lovely example of when we get things right, the great outcomes we can see. On the screen in front of you now, we just have Coloplast venous leg ulcer pathway. We will provide this to you later, but it's just a really quick little snapshot of a nice pathway to follow to manage venous leg ulcers. So as a bit of support, we'll send you this out, and also a little product choice guide as well. If you are using our products or want to know a bit more about our products, this little guide just helps you point you to the right product under compression as well. Okay, so that is me done in my little session. I'm just going to we're going to have a little break, but I'll just hand over to Rommel just to give you the what's going to happen next speech. So thank you for your time, everyone, and listening to that little ramble. The rest of the session will be super interactive. Rommel.
That's fantastic, Joseph. That was actually incredible. Oh, can you see the round of applause for you? Let's
thank you.
Thumbs up, round of applause. Absolutely a great session, and thank you very much. And there is quite a lot of chat as well. So I think there is a lot of agreement from the audience in terms of the importance of documentation and how documentation is integral to what we do, particularly from a nursing perspective. From the last case study that you presented, how was your documentation with that particular patient, may I ask?
Immaculate.
And I think it's just a
But it,
little joke there, but looking at the case study, you can clearly see the outline and the dates of your assessment there. So that's brilliant. And I think a couple of people commented around self-management and how important to get the patient
absolutely.
involved following you presenting the case study.
And
So
I think for this patient, it was a difficult for him to come to surgery because he was employed full time. At 67, he's an amazing gentleman, but he really, that was his life and that was his well being, and it was his mental health outlet as well. Working, he loved to work, and he was still as fit as an ox. It was just his venous leg ulcer. So when he started to come, he said, "I'm really going to struggle to be able to come." So once we got on that initial local infection, we started to see that improvement. We were able to empower him with all of the tools he needed, really simplistically, to take him to healing within 6 weeks. I mean, he couldn't believe it himself, having had it 18 months. But it just shows you when you get things right and you empower the patient, you understand their needs, how you can put the right thing in place.
it's about that ownership, isn't it? So it's
Yeah,
their wounds and
absolutely.
you're just there to help them. I think somebody mentioned around concordance that it's lovely if all of the patients will heal on that trajectory as you illustrated. But I think from a concordance perspective, hold that thought because on our next part of the webinar, which is the coronary code simulation, hopefully we'll talk a little bit more about concordance. So on that note, we're going to give you about 5 minutes break. So we will be back at 35 minutes past 2. So see you in a bit. Go and have a drink, go and have a little stretch, and I'll see you in 5 minutes.
See you shortly, everybody.
Let me share my screen. So much things I should have. There we are. Welcome back, everybody. Let me just unshare my slide because I think I need to share the one with audio. Include audio. Let's try that. There you are. Hello again, everybody. Welcome back to the second part of this webinar. So meet the coroners in court. Now, you have been a great audience. We can see a lot of interaction in the chat. And we can also see a lot of comments and sharing of best practice. So please keep this up. We need more of this in the coming session. So for the final part of this webinar, meet the coroner in court. This is a simulation, okay? So I repeat, this is a simulation. As I mentioned earlier, myself and Joseph, we are both tissue viability nurses. We are not a coroner. As part of the simulation, as I run through and facilitate this simulation, I'd like us all together, all of us, let us immerse ourselves and allow yourselves or ourselves to be transported into the courtroom, okay, as I share the video. And as the audience, I'd like you to take the role of the coroner and deliver your findings. So I will be showing 4 videos during the simulation. In the chat, you will also see one of my colleagues that's helping us, Charlie Lay. I think she's automatically muted, but if you see Charlie helping us in the chat, thank you, Charlie, for supporting. So without further ado, let's start the simulation.
I'm resuming the inquest this morning into the death of Elizabeth Mary Black, which was initially opened on the 27th of June 2021. It's my duty today to listen to the evidence requested in order to assist me in answering 4 questions: who the deceased was, and when, where, and how they came by their death. Who, when, and where are usually straightforward. It's how they came by their death I need help with. I confirm the deceased's full name was Elizabeth Mary Black. She was born on the 1st of January 1942 and died on the 14th of June 2021 whilst an inpatient at Spiral Down Hospital. In order for me to be able to issue a death certificate, I need to establish the circumstances surrounding Elizabeth's death. I will gather
Sorry.
evidence, and based upon that, I will then issue a death certificate. Depending on the evidence heard today, it may be that I cannot conclude death due to natural causes, in which case I will form a narrative version. Under Rule 42, no verdict shall be framed in such a way as to appear to determine any question of civil liability or criminal liability. That is for the courts to decide. Based on the witness statements I've received to date, I have decided not to have a jury for this case. I may have to reverse that decision should evidence come to light today that suggests a jury may be required. To assist me today, I have called upon witnesses. Elizabeth was 79 years old. She had a medical history which included hypertension, atrial fibrillation, type 2 diabetes mellitus, rheumatoid arthritis, and varicose veins. We've heard from the pathologist, who established the cause of death to be 1A, sepsis, 1B, cardiac failure, 2A, type 2 diabetes mellitus. The sequence of events started with a skin tear to Elizabeth's leg, which became infected, and sepsis then developed, requiring the limb to be amputated. Following this, further infection set in the surgical wound site, and Elizabeth never recovered from the surgery. We will hear from witnesses today to answer questions relating to the care and management of the wound in order to determine whether the wound sepsis leading to cardiac failure could have been prevented. Can I please call Ms. Brown to the stand? Can you please confirm your name and current employment?
My name is Ms. Brown and I'm the clinical manager at Boot Hill Nursing Home.
Were you involved in the care of Elizabeth, and in what capacity?
Yes, I was, as a community nurse at that time.
Can you explain to the court your experience and role?
I am a registered nurse and I had been working in the community for about 6 months, caring for Elizabeth. Prior to that, I had worked on the care of the elderly ward since qualifying last year.
What kind of things do you deal with as a community nurse?
We see patients who need injections, end-of-life care, pressure ulcer prevention and management, and lots of wound dressings.
Can you describe your involvement in the care of Elizabeth?
Elizabeth was referred to us by her GP to dress a wound to her left leg. She had caught her leg on a chair, which had caused a small skin tear. I saw Elizabeth the day after her doctor had visited and was concerned about a lot of leg swelling. The wound was quite small and I thought it would heal quite quickly, so I just applied a traditional adhesive dressing to her leg. That was on the Monday. I explained to her that everything should be all right for a few days and I would see her again on the Friday, as we were really busy that week.
What were your concerns about the swelling of her legs and what did you do?
Well, I wasn't too concerned. I mean, her legs were swollen, but a lot of our patients have swollen legs. And Elizabeth had just been seen by her GP, but I did leave a message asking the GP to review her.
I understand Elizabeth was visited again earlier than planned. Can you explain what you found?
Well, I visited on the Thursday, as Elizabeth's son had rung our office and requested an urgent visit. And I was really shocked when I saw Elizabeth. Both her legs were now swollen and leaking, and her son had wrapped some towels around them. And when I took the adhesive dressing off, her skin came away with it, as her skin was so delicate. The wound was now much bigger, and her other leg was also leaking.
What did you do?
I called the team leader, as I wasn't sure what I could do. And she told me to use a soft silicone foam dressing and to bandage her legs from toe to knee in a wool bandage and a crepe bandage until she could arrange an assessment.
What happened next?
Well, I was sent in to change Elizabeth's dressings regularly over the next few weeks, and I just continued with the silicone foam and the wool and the crepe bandage. I think for about 2 months or more, there wasn't much change. But some days they were quite smelly with more leakage, and some days they just looked worse than others. We kept taking wound swabs, and she had been on a lot of antibiotics, but she often didn't take them as they gave her diarrhea. I don't think she was going to bed, and I don't really think she did what she was told.
What did you do to encourage Elizabeth to go to bed?
I couldn't really do anything, as I can't make her. But she said she could get comfortable enough in her armchair with her feet on a little stool, although sometimes this made her heels feel sore. Eventually, the team leader was able to visit, and she did a Doppler and put some compression bandages on Elizabeth. At first, I couldn't do this as I needed training. So there was a course which I attended, so I could carry on seeing Elizabeth to bandage her legs. I thought I'd developed a good relationship with Elizabeth, so I was pleased I could continue to see her.
How did you feel her wounds were progressing?
Well, the wounds were getting a lot better, but Elizabeth was non-concordant and she kept trying to take the bandages off so she could get her shoes on or pushing them down. On one occasion, a previous nurse had bandaged from further back on Elizabeth's foot, so there was no bandages around the forefoot. I did the same, but by then her foot was so swollen she couldn't get her shoes on anyway. And as the wound was nearly healed, I decided to leave the bandages off altogether. I thought this would give the wound a chance to dry up and to heal properly. And I just continued with the foam dressing as Elizabeth was really unhappy.
Did Elizabeth's legs deteriorate?
Yes, they did, and ever so quickly. I panicked and I called the tissue viability nurse myself. The TVN came out and checked Elizabeth's Dopplers again and agreed that she needed compression bandages. And she talked to Elizabeth for a long time about how to rest her legs properly and the importance of proper bed rest, but also plenty of exercise and good nutrition. And she started her in strong compression. I couldn't believe how quickly Elizabeth's legs started to improve again. Unfortunately, though, she developed another infection. And this time she was admitted to hospital. And when she came home, her legs were open and leaking everywhere. The skin on her legs was raw. I don't know why they stopped using the bandages, so I just continued with the foam dressing, the woolen crepe. She also now had a pressure ulcer on her left heel, which she said she was admitted with, but I'm sure she never had any pressure ulcers when she went in. In the end, she was admitted again as she quickly developed another infection, but this time when she came home, she had her compression bandages on and she was on insulin.
Did her wounds start to heal again?
Well, at first they did, but then after about 2 weeks, I thought I could see a small bit of bone or tendon showing in the wound, but I wasn't sure. The wound was smelly again, and so I took another wound swab, even though one had been taken the week before. And I said that I would visit again in 2 days. The next day I spoke to the team leader, who requested another visit from the tissue viability nurse.
Why did you not document that you could see bone or tendon in the wound in your records?
I wasn't sure what it was I could see. But when I went back, it was obviously tendon with about 10 centimetres showing. So I rang the doctor, and the receptionist said she was unable to visit and she would ring me back. And when she rang back, she told me the doctor had prescribed antibiotics. But I was so worried, I went to see Dr. Porter myself. And when she eventually agreed to meet me and she saw the leg, she admitted Elizabeth straight away as she suspected sepsis.
Thank you. I have no further questions.
Okay, so I think that was a very interesting simulation to start with, to get you the feel of what had happened to the case of Elizabeth. Are we ready to launch the poll, Joseph, to see what the question is? Just to get the thoughts going.
A lot of information there that you probably need to digest, but we're gonna just start with the first poll, and the question is: was Elizabeth concordant? Okay, with care. So you'll see this pop up on your screen. If you can't see it on your screen, go into the chat, and it will be in the chat column. If it's already streamed on, scroll back in the chat to find it. Okay, so this is now in the chat.
Okay, so what was the question again? Was Elizabeth concordant?
Was Elizabeth concordant?
That's interesting.
Yes or no?
Okay.
So we've got 311 people in, and we've got 39 responses so far. So please go into the chat, guys, if it's not popped on your screen.
So
and choose one of the boxes and click submit vote. Sorry, Rommel.
Based on what you've heard from the first video, according to Ms. Brown, who is the community nurse who looked after Elizabeth, was she concordant with the plan of care? Now, it's a very interesting question, really, particularly. You'd think it's a straightforward answer that we'll get here, but let's see what the discussion points after. But I'll be interested to know, all of you guys, what do you think about it? Was she concordant with the plan of care? So there was about 316 of you. I've noticed my last count. How many has responded to the poll?
Currently got 135 respondents, with 83% saying no and 16% saying yes.
Okay, interesting. Most of you think that Elizabeth wasn't concordant with the plan of care. And I think you probably have been influenced by Miss Brown to what she said, that Elizabeth wasn't concordant. But really, was she? Let's have a look. Now, you can do better. There's about 312 of you. Let's see whether we can reach close to 200.
So we've got 144 now.
Okay,
82% saying no, 17% saying yes. Lots of comments. Thank you for people putting comments in as well.
Okay.
A couple of people saying yes. I don't think she had enough info. Annabelle, thank you.
Great. And I think I'll start the discussion from that bit, Joseph, because concordance in itself, if we look at what the definition of concordance is, it's about following that plan of care, that shared decision plan of care from the clinician to the patient. And I don't think there's a shared decision making there to start with Elizabeth. I think she was told that she needed this, particularly if we talk about compression and in concordance in relation to that. And there was not much explanation around that. So she had problems with her footwear. So she started making some adjustments to accommodate her footwear. So from that respect, I think there's a difference between a clinician saying to a patient, you must comply with compression therapy versus these are the benefits of compression therapy. These are the reason why we started on compression therapy. Because when the tissue viability nurse saw Elizabeth and spent a bit of time in terms of explaining the benefits and the importance of compression, the benefits of getting into bed and leg elevation, exercise and good nutrition, Elizabeth started to comply with the plan of care. So, and I think really with good explanation and getting Elizabeth on board with the plan of care, she probably would have followed the plan of care. What's your thoughts, Joseph?
I think ultimately we don't know for sure, but I think based on the information she was initially given, she wasn't given the information to be concordant. She didn't understand ultimately what they were wanting to do. It improved significantly once the tissue viability nurse had been there and explained things to her, which probably shows that she did have the capacity to understand and actually be concordant with her care. A couple of people in the chat have mentioned no mental capacity completed. That's right, it's not been mentioned, but for reference that she did have full capacity. It isn't mentioned on there, you're quite right, but she did. So she would have been able to understand what was being said to her. But most people now in the link putting, yeah, they absolutely think if more information, she probably would have been concordant. So yeah, I think most people are absolutely right.
I think what is important to add here,
sorry, Judith said the question didn't allow for any answer other than yes and no. And yes, Judith, that's because we wanted to stimulate the response because it isn't clear really, but it is that level of understanding of what is concordance we wanted to then flesh out, and also highlight the importance of information given to the patient. Is how you ultimately gain a lot of that concordance, empowering them with the knowledge of what's going on and what they need to do.
Absolutely. And I think from my perspective, particularly patients with leg ulcerations, for example, or patients with pressure ulcers, the complexity of this cohort of patients, we need to do a lot of things with this for these patients. Now, I think from my perspective, right from the get-go, it's important to establish that good rapport to these patients. So by establishing good rapport, you're able to influence the decision-making process with them. Now, Joseph, I know you're very good at this in your clinic. I've seen you in clinical practice, and you're very good at establishing the rapport with the patients. Which is key, as I said, because it's their win at the end of the day. And we as clinicians, we are here to help them and to support them. So from my perspective, I think that's important to consider from the get-go.
Absolutely.
Anything to add? What about barriers to concordance? What's your thoughts about it? Any thoughts about the barriers to concordance? I think as clinicians, it's important that we know how to troubleshoot in terms of barriers to concordance. For example, again, in bringing back the Elizabeth case, I think the problem there is I think she probably wanted to use her own footwear, but obviously compression bandaging wouldn't allow her to do that. Hence, she's adjusting that. There's other treatment strategies from a compression perspective that we can consider to allow our patients to follow a plan of care. For example, compression wrap system or compression hosiery, for example, if that is suitable. So it's about that problem-solving skill to make sure that we adapt our plan of care that is acceptable to a patient.
Yeah, absolutely. And some great comments here to address that as well, Rommel. Catherine says that equipment continuity, pain management training should have been looked at. Patient information leaflets to patient can have that takeaway to digest. Again, is something that's really good to be able to provide that. Someone saying, or Keraped shoes, that's absolutely true. If a patient's unable to get their footwear on, is there any way that we can give them something that will fit with the compression bandaging? And someone else said, was another form of compression needed to allow her to wear her own footwear? Absolutely right. Would she have been finding a wrap system that may have allowed her to get her own footwear in, or even compression hosiery? But those things clearly weren't explored. So yeah, some really good points coming up. Thank you guys for commenting.
Absolutely right. I completely agree to all of those points that's been mentioned. And I think it's pretty much what I've said as well. So I'm glad we're all in agreement and the same page. So hopefully that gives some insights to others that are new to the profession of nursing and management of leg ulcers. So right, more points of discussion. Let's pick a couple. So do you feel, or what could have been done differently on the first presentation of the wound? When Miss Brown, as the community nurse, when she first saw Elizabeth, what could have, well, what should have been done differently on the initial assessment and presentation of the wound? Was there a delay in compression on lower limb assessment and initiation of compression therapy?
So brilliant. We've got a couple of responses coming in. Holistic assessment. People saying that's absolutely spot on, everyone. There was significantly lack of holistic assessment by the nurse on the initial review. So that's exactly what was going on. Oh, chat's going crazy.
I love it when they go crazy.
So, brilliant. No implementation of light compression in the absence of red flags. Brilliant. Holistic assessment and education of the patient. Really good. Thank you, Rhiannon. I think there's a good delay in assessment. Wound assessment. Marie's popped up here as well. Doppler lower limb assessment. Wasn't raised to superiors early enough. Absolutely. So yeah, lots of really good comments here. Most of them, yeah, absolutely right. What we're really looking for is the lack of holistic assessment and the implementation of those early good strategies such as reduced compression that we could have done.
And I think that the most important thing there, you are all absolutely correct, is the lack of screening of red flag from the get-go. Policies are here, national recommendations are in place to make sure us clinicians are aware of best practice. Best practice in lower limb management has been around for a couple of years now. So patients like Elizabeth, we should have screened her from the get-go in terms of red flags and started her on mild compression. So we don't need an ABPI reading at that point. Start her on mild compression, and then refer on for a full ABPI. But in Elizabeth's case, sadly, she waited for a couple of weeks before it was escalated. Once it escalated, she waited for a couple of months before she received an ABPI. So there was a significant delay there for Elizabeth to receive the gold standard of care from a management of leg ulcerations. So it's not timely at all. So absolutely, you're absolutely right there. Right, controversial thing here. So another point of discussion. Did she require the multiple antibiotic therapy that she received? Did she require all of those? Now, I know there's limited content here and clinical presentation that we've shared with you, but just judging based on the simulation and the journey of this patient, did she require the multiple antibiotic therapy? Should she receive antibiotics with a prescriber seeing the patient? Now, that's even more intriguing.
Well, here we go. Chat's lit up.
Okay.
I always love to say that. It's lit up. Sound like American. No. Lots of people saying no.
Okay.
Some people saying no. Swab taking, yeah, no, I don't think so. Would depend on local protocol. That's a really good point. As local protocols do differ around the prescription of antibiotics and wound swabbing. Absolutely. No. Antimicrobial injection should have been used first, for local infection. Good.
Ooh, I like that.
Thank you, Claire. Yeah, that's really good. I'm sorry, my chat just moved so quickly when
I
people
think
are
let me
replying.
pick up what Claire's point. Claire, you're absolutely right. I think antibiotic therapy can sometimes be abused by other clinicians, really sadly, particularly in the case of leg ulcerations. You've got venous eczema, erythema around edema related or eczema related to lower limb. And sometimes it's easy for other clinicians who don't fully appreciate and understand the signs and symptoms of a true venous disease will reach for antibiotic therapy. And really from a wound infection perspective, we should be managing local wound infection with antimicrobials, not antibiotics to start with, i.e. good wound preparation and a choice of antimicrobial therapy that can manage the symptoms of the wound. So yeah, absolutely spot on. Anything else, Joseph?
We're saying, let's have a little look. We've got amount of antibiotics is only a stopgap and really more involved investigations may be more helpful. Some Louise, yeah, absolutely. Incorrect treatment given. That's brilliant, Louise. She wasn't assessed holistically, so not sure if she needed them or not. And that's ultimately the crux of it, isn't it?
Yeah.
With no holistic assessment, with the proper steps put in, had they been put in, would she have developed an infection? I think we can probably lean on saying maybe not, really, but ultimately we don't know, but probably not. So yeah, really good. Or a great little point here from Leslie. Wounds stuck in the inflammatory phase can look infected, but swabs and serial reviews can eliminate that idea. Yeah, absolutely.
And I think
Holistic
talking
review from
about
GP and nurse
holistic,
should have been collaborated together.
yeah, I think just picking up on the holistic assessment really there and looking at antimicrobial stewardship and the management of wound infection based on best practice from the use of systemic antibiotics. So I'm talking about oral antibiotic and IV antibiotic. From a wound perspective, if we are seeing spreading wound infection, so not just marginally spreading wound infection or signs of spreading wound infection or systemic infection, then we should be using antibiotic. But in the absence of that, it's about the use of antimicrobials. Let's pick up about wound swabbing, shall we? So did the ulcer require swabbing?
Shall we
Oh.
pick that up in a minute, Rommel?
Oh, go on.
Let's watch the next one, and then
Okay.
I think we'll pick that up.
Let's go. Let's watch the next simulation. Here is part 2.
I now invite Mrs. Smith, representing Community Services, if she has any questions.
Thank you. Yes, I do. Am I correct in thinking that the community nursing team you were working in was under a lot of pressure at this time due to sickness and the taking over of another patch?
Yes, it was terrible. I was missing my lunch breaks and working late every day. There's only so much you can do with 20 or more visits a day.
Did you keep measurements of the wound and report them to your team leader?
Yes, as much as possible, but I knew how busy the team leader was, and she didn't always have the time to listen to me.
Would you say that you had developed a good relationship with Elizabeth?
Oh yes, but she could be quite naughty and non-concordant at times. But we mainly had a laugh about it.
No further questions, Your Honour.
Ms. Best, representing Dr. Porter, the general practitioner, do you have any questions?
Yes, thank you. I notice you took several wound swabs. Did you ever discuss these with the doctor?
Not directly, but I rang and spoke to the receptionist.
Why is it that I cannot see any evidence of this? Did you record it anywhere?
No, I expected the receptionist would record this information in her records.
Did you not consider it important to record your conversation?
Well, not really, as the doctor wouldn't see it in our records, would she?
No further questions for this witness, sir.
Thank you, Miss Brown. You can stand down. I'd like to call to the stand our second witness, Dr. Porter. Can you please confirm your name and current employment?
My name is Dr. Porter and I'm the lead GP at the Sunnyside Surgery.
Were you Elizabeth's named GP?
Yes.
How many times did you see Elizabeth between November 2020 and June 2021?
Twice. Once when she first injured her leg, and then again in June when the community nurse alerted me to the deterioration and I had Elizabeth admitted to hospital. She was also seen earlier in the year by the practice nurse for disease monitoring.
Would you say it was normal for a GP not to visit more frequently for someone with a wound of this nature?
Yes, I would say that's normal. I would expect the nurse to take the lead in wound management.
Would you have been aware of the risks and the deterioration of the wound?
As I said, I would expect the nurse to keep me updated if there are any problems.
Clearly, the nurses tried to contact you.
Please don't interrupt the court. You'll get your chance to ask questions later. How did you manage the results of the wound swab?
I would have only acted on the results if the nurse had contacted me.
Did you know that the nurse contacted you after the swab was taken at the beginning of June when she was concerned that the wound was swelling?
I can't answer that question. I have no details of that conversation, so I have no evidence that it ever took place.
How did you communicate your concerns to the hospital staff when you arranged admission for Elizabeth?
I had a telephone discussion with the on-call vascular team.
And was it your impression that Elizabeth would be admitted straight to the vascular ward?
I presumed, possibly. Well, I suppose I couldn't be sure, as I don't know how this would be dealt with in acute.
Thank you. I have no further questions. Ms. Best, any questions?
I don't have any questions.
Mrs. Smith, do you have any questions?
Yes, I do. Dr. Porter, why did you not visit when the nurse first rang you?
Well, I would have been in surgery at the time. I said I would prescribe antibiotics, and I did speak with the nurse as she was very insistent. And I did actually visit at the end of my surgery.
Is it common that there is a failure to record telephone conversations?
I can only presume that the receptionist was too busy to record all calls, but she was adamant that no one called about Elizabeth.
Do you think that you might start getting the reception staff to record all telephone conversations?
I object to this line of questioning, sir.
I agree. Please move on, Mrs. Smith.
What did you think when you saw the wound?
I was very concerned and I arranged for urgent hospital admission.
Why did you not write a letter to go with the patient?
I had discussed Elizabeth on the telephone with the on-call vascular team. I didn't think a letter was necessary. I had very little time and I expected the wound to be looked at straight away.
I have no further questions for this witness.
Thank you, Dr. Porter. You can stand down.
Right. That was interesting, guys. So since I like Mrs. Smith. Now, Mrs. Smith is the one representing or legal representation for the community services. And you've heard from Miss Bess, who is the legal representation representing Dr. Porter. And you have here Dr. Porter's accounts of the event. So shall we launch the poll, Joseph? And I think this is probably in relation to wound swab, if I'm not mistaken. Is it?
It is.
Go on.
Rummel. So obviously the wound swab and the wound infections are quite the big thing here. So this poll is just, we just want to know when is a wound swab indicated? Okay. When is a wound swab indicated? Should pop on your screen now. The answers are if wound is not progressing, if the wound is locally infected, or unsure. Again, might be a bit of ambiguity here, but this is to stimulate a bit more a chat.
I'll be
So we'll
interested
give you a couple of minutes to quickly do this. We've got 303 people still on the webinar, and we're currently at 40 responses. And we've got 50% if the wound is not progressing, and 52% if the wound is locally, oh no, sorry, it's changed already. 55% if the wound is locally infected, and 41% if the wound is not progressing, and 3% unsure currently, and that's at 92 responses.
Okay, that's good. Well, because remember Miss Brown, the community nurse, she took a couple of swabs, bless her. She couldn't see the result initially, and then she took another wound swab, and I'm sure other wound swab was taken along the way. So it'll be interesting to see what your thoughts in terms of appropriate, when is the appropriate time to take wound swabbing. How many have responded so far? Have we got, how many responses?
121 responses, 58% if the wound is locally infected, 38% if the wound is not progressing, and 3% unsure.
Okay, let me just kick this off there. I think clinical context is required, isn't it?
Absolutely.
From this point of view. Now, I think what I would like to say from a clinical stance is we should not wait for a wound swab, for example, or the result of a wound swab to diagnose a wound infection. Diagnosing a wound infection should be based on local signs and symptoms. The only reason or part of the reason that we take a wound swab, if we want to identify or if we need systemic treatment, i.e. the use of oral antibiotic or IV antibiotic, because we need to know what that microorganism growing at the wound bed so we can target it with the right antibiotic therapy. And outside of that, there could be, depending on your local policies and procedure, in the acute setting, some of you will require wound swabbing on all wounds that will come through the door to make sure from an MRSA screening perspective. Some other reasons are if the wound, for example, you've tried antibiotic therapy, antimicrobials, and you've explored other etiologies, and that's okay, and you still got a non-healing or slow to heal wound, then that is another reason to take a wound swab. Any other thing from the chat or anything from you, Joseph? What's your thoughts?
A couple of people rightly asking for more information, and that's the thing. Often we don't have more information, but that's what we really do want. I think the correct answer, if there is such a correct answer in this poll, would be if it's locally infected. The reason being, and yes, if it's locally infected, what we should be doing is treating with a topical antimicrobial, really good wound preparation to reduce that bioburden, and hopefully we prevent a spreading infection. But if we're worried at that local stage and we take a swab, then hopefully that's going to tell us the causative bacteria. So if it does swab, if it does start to spread, then the GP already knows what the most likely best antibiotic is to prescribe. So that's kind of the reason for the answer. But you're all right, more information absolutely needed. But always remember, wound swabs don't diagnose infection, as Rommel said. They just tell us really what causative bacteria is. We always diagnose that infection on the presentation, if it's local or if it's spreading.
And I think the important thing to add on that, Joseph, it should not delay your treatment in terms of
Yes.
the use of antimicrobials and other treatment modalities that you want to use to your patients from a wound preparation perspective. Right, let's have some more discussion then. Okay, right, this one. Why did you think the solicitor representing the community and the GP were asking the questions the way they did? Why did you think the solicitors were asking those type of questions and asking the way they did during the inquest? Any idea? Anything?
So, oh, hang on, here it goes. Here it just pops. So to make change and suggestions to highlight mitigating factors,
Yeah.
want to divert blame towards the GP, to bait a reaction. Oh, there's some good stuff here. Because they felt she could have done more and documented better. Lack of community to assign blame, to apportion blame, to assign responsibility, to decide who is at fault. Not satisfied with GP's involvement. Oh, my chat is going to blame each other. Yeah, a lot of blame going on here.
I think from a legal representation point of view, they are there. So if you were being called to a certain inquest, you will have legal representation to support you, and their duty is to put you under trust in a good light. Not so much to apportion blame to others, but I think we probably know what they're trying to do. But it's putting you guys under trust in a bright light, really, and try and explore some of the evidence that's been presented by the other parties, to really authenticate what they're saying is true. And this is when documentation will be handy in terms of supporting those facts that's been presented in the court. Joseph, you're going to say something?
Just saying, Sharon said gaps in policy and procedures. Yeah, that's often what they're trying to do, is to highlight that to, or the opposition one is trying to do, trying to make the other party incompetent. Lack of evidence in documentation. To ascertain if standard operating procedure has been followed.
And I think sometimes it's about to understand the reasoning behind the decisions that were made. Why did Ms. Brown escalate at whatever point? Why did she take the wound swab? Why was compression taken off when it was close to healing? And they want to explore as well whether there's also omission of care and highlight those to apportion blame, for example. So I think it's an exploratory process, and that's what they're trying to do during that process. So next point here, shall we have a look? Workforce, how does this impact in the priority of care for patients and the handover? To senior colleagues. So workforce, how does this impact in the priority of care for patients and the handover to senior colleagues? Remember, Miss Brown escalated it to the team leader, and it was highlighted.
Just want to quickly highlight that Martha there has just put on my Bible a link to the Bible, the IWII Wound Infection Institute clinical guidance on how to perform a wound swab as well. So thank you for that, Martha. Yeah, it's a really good resource.
So in terms of workforce, going back to the question, how does it impact prioritization of patient care and the handover or escalation to a senior member of staff? Do you do that in your own practice? Do you complete an incident form when you're short-staffed or when you are under pressure, for example? I think Ms. Brown, Ms. Smith, the community service legal representation team, was trying to paint a picture that the service was under a lot of pressure during that time.
So we've got a couple of people putting a few things here. We've got Sarah saying skill mix, no overview from senior member of staff, not completing all assessments.
Interesting points on the skill mix.
You should have a duty of care, Carol's saying, to the patient, even if your team is busy.
Yep.
Catherine saying short staffing equals overloaded with visits, can't be thorough and comprehensive as like to be due to essential visits. All staff overloaded may not have a good handover or even see each other. So that she's referring to there's a lack of communication often that prevents proper care from being put in. Someone saying skill mix in community teams and other issues, sickness, annual leave, but this doesn't impact the visits that need to be completed.
Okay. And I think what
low leadership or management apparent. Carmen saying at this stage she feels.
I'm just going to put it out there as a food for thought. Okay. Do you complete an incident report when there is a great if you are short staffed and you are expected to deliver a high proportion of workload and you just think, I just don't have the staff or the resource to manage this. So it's just food for thought, really, and looking at documentation and how that can support us in the future if we are being called, for example, to produce evidence to investigate as part of an inquest. So just a food for thought there in terms of incident reporting. You mentioned earlier, Joseph, around documentation, and I think the last discussion point here. Are we ready for the last discussion point?
Can I just say, there's a couple of people with their hands up. Nicola, is anyone want to say anything? There's Nicola first, Nicola East. You've got your hand up. Sometimes that's a mistake. Just wondering if it is. No, and Lee Smith as well with his hand up.
Oh, no, Lee's his hand down. Okay.
No, you don't have to. Just is the Lee? It's gone back up.
I think it's just a button. It's just a button. Okay, right. Let's go for the last discussion point. Let's go for the last discussion point. Do you document all contacts with other professionals, patients, family members? What could be the outcome if this is not documented?
Hang on. Everyone's muted. So can people not unmute themselves?
I think if I'm not mistaken, it's probably we have to physically unmute them, go through it and find it if we can.
So guys, if you've got a question, try and put it in the chat for us, because I think that it's really difficult then if everyone comes on. So that's why we keep everyone muted, and we'll try and answer the questions in the chat. But yeah, from what you were saying, Rommel, lots of people here now saying yes, document all contacts. Thank you, Charlie. See here.
Okay, so do we document all contacts with other professionals, patients, and family members? Was the question there. I can hear from you, Joseph, that you're saying that the audience is saying yes and yes and yes, and there's quite a lot of support from that. And I think that is important. I know we are busy and what we're trying to do day in, day out, but for any key informations that we think it's vital for the care of this particular patient, it is important to document those.
Okay, I've found it. So, Nicola, you still got your hand up. Would you like to say something? Mike's on if you want to.
Yeah, it was just it's saying I'm no longer a participant. I've left and I've rejoined, but I can't have access to the chat and I can't write anything.
Oh. Okay.
I'm just wondering.
I'll see if I can get my tech support on that. I'll have a try.
So I haven't been able to see the chat or anything, or like join in.
Hi, sorry. It's taken until now to be able to communicate. I can't do anything on the chat.
Okay, right. So there's a problem with the chat. So it's I'm not sure whether it's the system that you're using or it's the platform that currently we're on, but others can still access the chat, isn't it, Joseph? Have you got any questions, Lee?
Yeah. I'll see if I can get some tech support to see why that is happening for a couple of people. Okay.
Yeah. To be honest, I feel so frustrated. I can't remember what my questions were that I did want to say, but I haven't been able. I have not been able to participate. I've just been chewing at the bit, wanting to.
Oh, we apologize, but I'm glad that the intentions were there. We apologize. Okay.
I'm sorry, Maggie.
Right. Shall we go through the next simulation? Okay. I think for
Yeah,
the
let's go.
purpose of this webinar, and let's try and use the chat function for participants. Hopefully, most of you, if not all of you, can use the chat function. If you can't, I'm not sure whether it's your end or our end. I apologize. But yep, let's keep the discussion going. I'll now show you the third video, this third simulation, and let's see what your thoughts are. Okay.
I'd like now to call Ms. White to the stand. Please confirm your name and current employment.
Yes, I am Miss White, and I am the Advanced Nurse Practitioner in the Accident and Emergency Department.
How long was Elizabeth in your department?
She was prioritised as per our targets of admission within 4 hours.
And what treatment did Elizabeth receive?
She had been started on intravenous antibiotics, as I was sure she had an infection.
Where was the infection?
It was unclear initially, but we now know it was in her leg.
Am I correct in understanding that the bandages were not removed from Elizabeth's leg whilst she was in the Accident and Emergency Department?
Yes, that's correct.
Is that usual practice?
We have very few bandages in the department. We see lots of patients coming in with bandages on their legs and often compression, and we don't have any compression bandages. If we did, the nursing teams are not trained to apply them.
Would you always remove bandages now?
Oh yes, straight away. We have a good supply of dressings and bandages now, and pathways in place for any patients who come in with leg ulcers.
How did Elizabeth seem to you?
Not very well. She had tachycardia and raised blood pressure. Bloods were requested, and inflammatory markers were very high, as were her blood sugars. She was showing signs of infection.
So why did you not remove the bandage on her leg to check the wound for infection?
Well, I actually suspected a chest infection, and I did start her on intravenous antibiotics. I did not realise she had an ulcer. No one had told me, and it was a very busy day in the department.
Was the vascular consultant called to see Elizabeth?
No, I arranged for Elizabeth to be admitted to the medical ward.
Were you aware that Elizabeth's GP had spoken to the on-call vascular registrar?
No, I was not made aware of that call.
Thank you. I have no further questions. Mrs. Smith, any questions for this witness?
No, sir. I do not have any questions for this witness.
Ms. Best, do you have any questions for this witness?
Yes, if I may. What I cannot understand is how this lady came through the Accident and Emergency Department without anyone looking at her wound. Could you shed any light on this?
We are not wound care experts and have little experience of treating ulcers in A&E, but we have since had some training on wounds and leg ulcers from our tissue viability team.
Perhaps you may make more of an effort next time.
Please think carefully about your line of questioning. This is not helpful to the court. Do you have any further questions?
I apologise. I have no further questions for this witness.
Thank you. Thank you, Ms. White. You can stand down.
That was quite interesting, wasn't it, from Miss Bess, the legal representation from representing the GP. It's the line of questioning, I think, is what she was saying, and I think I'm with her when she says that she doesn't understand why the compression bandage wasn't removed when the patient was in A&E presenting with potential signs of sepsis. But let's see what the poll is. Go on, Joseph, launch the poll.
So the poll this time, guys, is removing compression and stopping this therapy harm? Okay. Is removing compression and stopping the therapy harm?
So reflect on what had happened with Elizabeth and the journey that she had from the community to A&E. So was removing compression therapy harm? If they had decided to remove it, was it harm? Or would it be considered harm? Okay. Again, you're probably thinking more context is required, but again, as Joseph keeps saying, this is the purpose of the simulation and the discussion points. But overall, in general, what's your thoughts?
Okay, so far out of 293 people still on the webinar, we've got 98 responses, 103 responses, sorry, 55% saying it's not, 45% saying it is.
Okay, right. And I think from a discussion perspective, really, and you know, more context is required, really. And I think in Elizabeth's case, from my perspective, it's not considered harm in Elizabeth's case because it needed to be removed from the get-go when she presented in A&E to explore the signs and symptoms of wound infection. Now, the advanced nurse practitioner who saw Elizabeth suspected, is what she said, she suspected respiratory infection. Now, she wasn't unclear, or she wasn't clear of where the source of the infection is. And looking at Elizabeth having a compression bandaging in situ, that should have been removed. And but some of you that is working in the acute setting will probably say that it's part of the skin inspection, looking at pressure ulcer prevention and management, and also from a MRSA screening point of view, that compression therapy should have been removed to cover those aspects. So on that context, it's no. In the context of removing compression therapy with no justification or reason, probably is. But again, if there is a good clinical indication or rationale of removing compression therapy, then we should be documenting it. And equally, if we don't remove it, for whatever that reason is, we should be documenting those reasons as well. Any comments, Joseph, from the chat or from you?
Yeah, we've got some really good comments. So Sarah said in this instance, no, as the wound review would be required and they could refer to the tissue viability team or vascular team to recommence some review. And I think that's spot on. Absolutely, if we're looking for a source of infection, we have to do a top-to-toe inspection. And if we know the patient's got a wound, that is a viable source of infection. We can only diagnose an infection in the wound through clinical presentation of that wound. The compression has to come off. It's not harm because we're preventing further harm. And with referral to specialists, the TVT team, vascular team, hopefully they can come in and say how we manage that lower limb while they're in. And often it's probably not going to be compression because a lot of hospital staff aren't trained and don't have the frequency to be able to apply compression. But we would be safeguarding it by getting that information from the specialists. So that's a really, really good point. Kerry from Sheffield saying could have been removed and rebandaged post-examination with wool. K-like whilst waiting for specialist TVM review. Absolutely.
And that is a good point, really. And I think from a skin inspection perspective, examining a wound perspective to look at that source of infection, applying a standard or basic management to a lower limb without compression therapy, if they are in hospital, leg elevation would support venous return. So that can address some of those venous congestion. So it shouldn't be a fear, really, of removing compression bandages when they are in the acute setting.
Unfortunately, I think from our own experience, I think it's being acute tissue viability in this. I think we know that the fear is real in a lot of acute settings about compression bandaging. People are worried they're not involved in the care. They don't know what compression bandaging, they don't know if they're going to cause further harm by taking it off. And I suppose it's up to the institutions to be able to educate their staff on, look, assessment takes precedence over everything. It's about getting the referrals right, the assessment right. You'll get those right referrals and we'll put the plan in place to make sure there is no harm. I think that's ultimately what we're really looking for.
Okay,
hold that really good, really good, really, really good. I love this one. I love this one from, sorry, Catherine. Well, the GP would have had to take the compression down to assess it before sending him to the acute. Surely the GP didn't put it back on. I think I've never known a GP to do compression bandaging at all. So that's a very good point. Maybe this is just a highly skilled GP who had the nurse with her.
Okay, well, let's hold that thought. that's quite funny. Why do we think dressings are not removed in A&E departments? Okay, why do you think that dressings are not removed in A&E departments? And what can be done to change this practice? Any insights? Any insights from the group?
Sorry, my Chat's going crazy. Lack of training, lack of training, lack of training, time and education. Absolutely. Lack of wound care knowledge needs training. Understanding, lack of knowledge, time and volume of patients absolutely is a good point. Stop staff members not having training. A lot of the same things.
It's the lack of awareness
Time, lack of
and lack
training.
of training. Absolutely spot on. And I think it's the lack of awareness. And I think you pointed it out earlier, Joseph, in terms of depending on local policies and procedure and potentially the rationale on why it's okay to revert compression, that it's not that all scary, really. So, and I think education will play a big part in terms of changing practice in A&E departments. Now, I hope and if you are here in this webinar and you are from an A&E department and you are encountering similar challenges that you witness from today's simulation, and I think sometimes going back to clinical practice and implementing those change and could make a significant difference. And not just implementing those changes in clinical practice when you go back, but also celebrating those success. Because once celebrating that success, it cascades to any other A&E department across the country. So if you got good examples in terms of how you resolve this kind of challenges or issues in your department from an A&E perspective, please share them. But really from a training and education perspective, that is what is required. Prescriptive pathway would help. In terms of guidance, standard operating procedure, for example, for patients coming into A&E department with lower limb wounds and how to manage them in terms of immediate and necessary care in A&E would probably help. Any other tips, Joseph, that you can think of?
I think ultimately it is just about education. And if you are unsure, it's about asking. And don't be scared to flag up where you think there is a gap in care in your organisation. If you're working for an acute and you're noticing this is an issue within your hospital, flag it up. Be that voice to say, look, this is a gap in our care. We don't have that policy. We don't have that procedure. We are opening ourselves up to harm and harming our patients. Let's educate people on patients coming in with compression bandaging and what we should be doing. I think that it's important that we speak up as nurses. And that we make our voices heard when we notice that is an issue, and we don't just think, oh, let's wait for someone else to say it. It's all of our responsibility ultimately.
I think great point there. And the theme of this week's Legs Matter is about speaking up and voicing up, and not just from a patient's perspective, but healthcare professionals equally the same. So speaking about good practices and sharing those, and equally if we got some challenges, and you mentioned there around escalating it or referring it on to somebody who knows what they're doing. There's always help in the acute. It might not come immediately, but there's always somebody that you can refer into. And I think that brings me into my next point around mentorship, for example, or clinical champions within your clinical area. So if not just in A&E, but overall, if you are seeing a significant proportion of the patients that you're seeing have complex lower limb wounds, is seek mentorship with somebody who managed this cohort of patients, has got the skill to be managing this group of patients. So, and I think the best way to learn is on the job, isn't it? Particularly from a wound perspective. So shadow them or get them to help you in terms of managing this group of patients. Right. Let's go into the last discussion point for this video then. Whose responsibility is it to remove the dressings and assess the patient's leg? Was it a nurse, a healthcare assistant, or the doctors? Whose responsibility is it to remove dressings and assess the patient's leg or any part of their body? Registered nurse, healthcare assistant, the doctor, everybody? Whose responsibility is it?
So everyone, here we go. It's all coming in. Everyone, anyone completing an assessment, first person to assess, whoever is assessing the patient, everyone, everybody. I think you're all right. I think ultimately, yes, that the first person who's assessing is, but if they get pulled away for whatever reason or something happens with that person,
Hello?
Person, yes, the assessing nurse should be doing that and taking it off and make sure it happens, but it's also every healthcare professional's responsibility to make sure we're supporting each other and that things are getting done. And often as nurses, we know that we're the ones who have to pipe up and say to doctors, sometimes you have to do this, sometimes you have to do that. That should be a shared responsibility sometimes, and we shouldn't ever take offense from that. We should be literally just supporting each other to make sure we are being holistic in our approach to our patients and everything's getting done.
That is an excellent point you made there, Joseph. It's everybody's responsibility, really, in terms of skin inspection and wound assessment wherever this patient comes into our department. And it's up to us to seek those skills in terms of how we manage this particular group of patients into our caseload. Right, let's look at the last simulation. Video 4.
Can I call Nurse Spears to the stand? Can you confirm your name and current employment?
I'm Miss Spears. I'm a registered nurse, but I've moved from the medical assessment unit and I'm now on the rehab ward.
Were you involved in looking after Elizabeth?
Yes, I was.
Am I correct in thinking that the bandages were left on her leg for a further 4 whole days before being removed?
Yes, that was normal practice when patients had been admitted from community. We usually find out when the bandages were due to be changed and change them on that day.
How did you know when Elizabeth's bandages had been changed?
Elizabeth told me. She was quite good at communicating. She did ask for them to be changed, but I said no because it was important we didn't disturb them.
How was Elizabeth being treated?
She was needing a lot of help to do things, and we were trying to encourage her to eat. And she was having intravenous antibiotics, and her MUST score was improving a little.
What happened when the bandages were removed?
I was horrified. Her leg looked like it was rotting. I'd never seen anything like it. So I called the doctor, who called the vascular consultant, and she was moved to the vascular unit. And I understand she had an amputation the next day. She was very poorly after surgery and had an infection in the stump wound. She was on critical care, and I believe she died 2 weeks after surgery.
Thank you. Mrs. Smith, any questions?
Yes, thank you. Miss Spears, would you always ring the community nurses to discuss the bandaging?
Not really. I'm not sure we need to. We are the people looking after her in hospital.
You told the court that you would ask the community nurse when the bandages needed changing, but it would appear that on this occasion you did not do so. Why was that?
Elizabeth could tell me when the bandages were changed, which was on the day she was admitted, so I thought they'd be all right for a few days.
What if Elizabeth couldn't communicate with you?
Elizabeth's son also says she had her bandages changed when she came in.
No further questions, sir.
Ms. Best, any questions?
Yes. Miss Spears, if a person is admitted to hospital with a wound, surely as part of their care, you should assess the wound.
I suppose you could say that.
Are you agreeing with me then?
Well, yes and no. I can see your point, but hospital policy is to leave bandages in place until discussed with the community nurse managing the care.
Was the management plan discussed with the community nurse?
I'm not 100% sure. I didn't talk to them, so I don't know if anyone contacted them.
There is no evidence that the ward staff contacted the community nurses at all.
Thank you, Mrs. Smith. Can I remind you not to interrupt, and then perhaps this expert witness can answer the question.
Was there any documentation in her records?
I'm not sure. I'd have to consult the records.
Well, go ahead then.
No, I cannot find anything about the community nurses.
No further questions, sir?
Thank you. Thank you, Nurse Spears. You can stand down.
Okay, that's the last video that you will see as part of this simulation. Interesting accounts there from Miss Pierce. Right, are you ready for the poll? Come on, Joseph.
Okay, so the last poll is, whose responsibility was it to care for the wound whilst the patient was in the acute care setting? Okay, quite simple on face value. Whose responsibility was it to care for the wound whilst the patient was in the acute care setting?
I think Miss Pierce talked about policies in terms of phoning community nurses around information around the bandaging. I think, yes, from a poll perspective, whose responsibility is it?
And also remember, if you feel like the poll's lacking, that's what we want you to do. We want you to put why in the comments.
Let's have a look.
So acute care nurse is currently winning, 86 people, 94%. 3 people saying ward doctor. 1%, one person saying GP, 1% saying community nurse, but the majority is easily there, 94% with the acute care nurse. 100 responses so far.
I think it's a conversation around responsibility and accountability, isn't it? And I think once the patient is admitted to an acute setting, it's the responsibility of the acute care setting to deliver that care, and ultimate accountability lies under the consultant where this patient is under. And sadly, in Elizabeth's case, due to the lack of communication and documentation, she was admitted to a medical ward instead of a vascular ward. So she probably would have been under ultimately in terms of accountability from a medical consultant to start with, and the responsibility is for the acute staff to deliver the care needed. Anything else from the chat?
So yeah, the chat's great. It's lighting up. It's really good. So a lot of people saying the problem, and this is absolutely the crux of the problem. The problem's communication. So we could all well saying should have, if have, can manage, but where's the handover of the care plan from the community? And yes, it can be difficult to put that through in an emergency situation, but the GP had a phone call with a vascular nurse. The patient was going to ED. Where was the letter? Where was the handover to ED? And I think that's a really, really good pit, which a lot of you are picking out in the comments. Where's the handover? Where's the handover? Where's that letter to GP? And you're absolutely right. Ultimately, I think a lot of you are saying it's the acute nurses. Yes, the acute are responsible now. Once it is in the acute, it is not the GP's or the community nurse's responsibility. It is the nurse in time with the doctor and all the healthcare staff in the hospital to now be managing that wound. But yes, a care plan and some information would have been really good. Oh, let me just have a little look at that. So Charlie's saying she delivered this session yesterday, and a question was raised, which we expect a discharge letter from the hospital when the patient is discharged, but the acute do not always get an admission letter. Communication between services need to be improved. And I think I would absolutely agree with that. Sometimes it is a bit tit for tat between the two, but ultimately I think no one can disagree with the fact that communication needs to be improved. And someone else made a point saying there's 3 different documentation systems used in their local area between hospital, acute, district nurses and primary care. Why can't we all just be on one so we can actively see? Wouldn't that be amazing? Wouldn't that be amazing?
Great point there, guys, in terms of communication, and I think just for the purpose of today's presentation, really, and the theme that we're running through, so it's not just about communication, but equally it's documenting what you want to communicate to other parties. Because I think what had happened, as you know, with Elizabeth, there were a lot of gaps in terms of documenting the conversations that the clinicians had, particularly over the phone, and the lack of discharge letter or communication from the GP to A&E, as you rightly pointed it out.
I mean, also, Catherine's made a really good point. In an emergency situation, you're trying to get a patient in, you're really busy. Have you got a printer? Can you quickly generate that letter? Often, no, you want to get the patient in, and it can be really difficult. Through our clinic, I've admitted multiple patients to hospital, to A&E, because they presented in my clinic with signs of ischemia, critical limb ischemia, or signs of acute systemic infection. When that happens, I want to get them in. Can I keep them in the surgery while I'm waiting to get them in? No, we've ordered an ambulance. But what I have done in the worst case scenario, normally you can print a review. You can handwrite a quick letter. I've done that where I've handwritten a quick letter. And there's one case where I've had to get a patient in, where I've had to send the letter electronically. I've contacted the hospital, got the contact at A&E, and sent a letter electronically after as well. So you can't. There's not one solution, but that we can always do something to try and get that communication across where we can. I think it was a really good point that was raised there.
Okay, that is a great point. There's always a way, isn't it? I know sometimes you are under pressure to deliver that care or get this patient into the acute setting, but yeah, handwritten letters, just print whatever you can as a form of communication, just to inform the other parties in terms of what that major concern is. So we're now very close to asking you guys on what your thoughts, on what your verdict as a coroner in terms of the form of judgment. But let me just remind you of the case. So Elizabeth Black, she initially sustained a skin tear to her lower leg, was assessed by a community nurse. Sadly, no red flags was screened, and she wasn't started in compression earlier on. She waited for 2 weeks for further escalation, then a couple of months before she had an ABPI and compression was started. When she was close to healing, it was discontinued for whatever reason, following an admission to the acute and discharge back to the community. And when she encountered complications of severe wound infection via the GP, she was referred back to the acute setting, wherein there was a miscommunication or lack of communication, really, and lack of documentation in terms of the concerns from the GP. Hence, her compression wasn't removed in A&E as part of the screening process. They were thinking it's more chest-related wound infection, and then she was admitted to a medical ward. Further on, she was referred to a vascular specialty, and she ended up having amputation, but because of for her poor medical health, she developed further infections for her amputated site, and she passed away, and she succumbed to her death. So this is what we're trying to establish now. So you've heard from all the witnesses and the legal representation representing all those witnesses and what that counts. So you're now ready to hand your verdict. So let's launch the poll, please, Joseph, to see what the audience think. Right.
We'll launch the poll. So the poll is what is the conclusion. Before I launch it, one thing I just want you to bear in mind is, was there a clear cause? If not, what would it be? If there's no clear cause, what would it be? So here we go. Launching.
Okay, yep.
Launch.
And to help.
There we go.
And to help you come up with your findings, I have put up in the screen the common findings from the coroner. Okay, let's have a look. 279 I can see. So I am expecting, at least let's go to close to 200, please. Let's give us your verdict.
So 50 responses all in so far, with 46% to narrative, 46% neglect. Oh, someone's gone in for unlawful killing. Someone would make a very harsh coroner.
But it's interesting, actually. Oh, this group is interesting. I know it's a low number, but come on, let's have some more. 46% narrative. Okay, good. Let's have a look at
responses so far, and we're pretty much 50-50 with neglect and narrative verdict.
Okay, right. Keep them coming. Keep them coming.
Neglect by all.
How many?
Neglect, narrative. We are at 120, and it's an even split between narrative and neglect at 46 and 46. Or 47 neglects just, no, it's narratives just popped ahead of 47, 123 responses.
I think this is a smart group. I think this is the highest so far in terms of group favoring narrative versus neglect since I started delivering the session.
And just some of the comments, a lot of people putting in comments. So Victoria here says systemic failures from all parties, narrative verdict.
From all parties, harsh, but yes, let's okay, right. So I think all of you, or most of you who participated in the poll are looking
most
at
of the comments you can't. There's a lot of people who can't participate in the poll. It's not working for quite a lot of people.
I'm sorry, guys.
People are, if that's whack it in the chat. If that's not, I think the majority is narrative. There's a lot of neglect, but a lot of narrative verdicts people are given.
You know what? I think I'm gonna give that a round of applause. Brilliant, guys. You got it right. This is a narrative verdict from the coroner, where the coroner will have to lay out the circumstances of the death of Elizabeth. Really, it's not a neglect. The reason why is basic needs were provided to accommodate Elizabeth's needs. Really, so that was provided by all parties from the community and the acute setting. Elizabeth's needs were still provided from a basic needs perspective. So they haven't completely neglected Elizabeth, i.e., they just left her in bed with bandages in situ for months on end without even looking at it. But they did eventually look at it. There were some delays, but again, there's just some gaps in terms of delivering that care that Elizabeth deserves. So from that perspective, for the purpose of the simulation, it is a narrative verdict for the coroner. But I think the main question, or the other question, is would the coroner, you as a coroner, would you issue a Regulation 28? Now remember, as a coroner will issue a Regulation 28 if he felt that during the inquest that preventable death cannot be avoided following the inquest. But if during the inquest the coroner feels reassured that measures has been put in place, for example, in the hospital or in the community to mitigate that risk or to prevent the same case to happen again, then he would not issue a Regulation 28. So based on what you've heard so far, as a coroner, are you reassured that no further Elizabeth Black will suffer the same consequences in the community and in the acute? Would you issue a Regulation 28, yes or no? Put
And
in
the
chat.
comments have exploded with everyone saying yes, 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 yes,
Ooh.
yes, 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 yes. Absolutely.
Okay, fair enough.
So
Fair enough.
everyone's in agreement, and you are all absolutely right. There was no one clear cause that led to the patient's death. It's a multiple of other little things which, if corrected, would the patient have died? We will never really know, but potentially not. So because there are so many little ones, it's this narrative verdict, and with this Regulation 28 for the coroner to be able to say, I want insurances that you're addressing these issues that have been raised. Some issues may have already been put into place, but the coroner is going to want evidence that those are being done. And remember, they've got 56 days to reply and provide the coroner with the evidence that they have acted on that Regulation 28 order.
Interesting points, but yeah, I'll take your point on that one, based on the simulations and what you think as a coroner. So that's your judgment. So we have now come to the end of the simulation, and I hope you really enjoyed that, and we really enjoyed doing it. Thank you very much for all your participation, sharing your insights as well, and your comments are greatly appreciated from myself and from Joseph, and I'm sure to the other audience as well, because we all come in here with different experiences, and some of you have got more experiences than others. So thank you very much for sharing those. If you need any sort of more information around the products and services from Coloplast, I would encourage you to scan the QR code. I'll give you a second, scan the QR code and complete the form. And the person that you can see on the screen is our lovely Chloe, and our lovely Chloe will be happy to facilitate or assist you in terms of whether you want to know more about certain products like the All Prep Pad or the Biotain Silicone, or some of our products and services, i.e. I think one thing is good to mention now is our Coloplast professionals. So if you want e-learning to learn more about leg ulcerations, we have a web page called Coloplast Professionals, and that's something that you can have access 24/7 and you can share with your colleagues. Anything to add from you, Joseph?
Yeah, there's a couple of people asking if we have any other further dates running. What I would say to that is often we do run this session throughout the year. Scan that QR code and submit your details and ask for that information. And when it comes, we can be made it. But also keep an eye on our socials, the Coloplast socials, on Instagram and Facebook. And we often put on there when the new sessions are going live and the dates and the booking links through there as well.
And
So,
I think
yeah.
to add to that, if you type in Coloplast Professionals, if you log into or register into, you can see all our future events under the Coloplast Professionals banner. So you will.
Charlie's put the link on there on the chat.
Oh,
So if you can
thanks,
see
Charlie.
Lay's link, thank you, Charlie. Charlie's put the link to Coloplast Professionals on there, guys. So give that a click, register on there, and it will update you with the dates.
Okay. So
and thank you, a massive thank you from me for all of the interaction, guys. It's really helpful. It's really good to have seen all of your opinions and your feedback. So thank you very much.
Okay, right. I will let you enjoy the rest of your afternoon, and hopefully you enjoy that. And thank you very much for attending. See you soon in the future. Bye-bye.